Good morning, everybody. We're going to get started this morning, we're going to have Dr. Kelly Hahn speak. And on your way out, if you'd please say thank you to our session sponsors this morning, which are Pfizer and Janssen. We would appreciate it. And with that, Dr. Hahn, are you ready?
Yes. So I want to thank everyone for coming today, and I want to actually point out who's in the room. We have 2 neonatologists and children. We have people that are coming from mother-baby. We have people from MHI. I think it's a marker of what we're trying to do with this program. And so what I'm going to actually talk about is adult congenital heart disease and also cardio-pregnancy. And this really is a collaboration between all of children, the Minneapolis Heart Institute, and also Allina Health. I think MedPeds has been critical to this, anesthesia intensivists, and also the Minnesota perinatal physicians. And so what I want to do today is actually talk about 3 cases. And with these cases, what I want to do is illustrate the potential we have here and the challenges we're going to have for sort of building adult congenital. And so I think everybody knows this. I've shown this slide probably at every single talk I've ever given. But I think what it shows is that patients with really complex congenital heart disease, they used to die as infants. And so they don't anymore. Because of the congenital care provided today, almost all mortality in congenital heart disease is actually adults. And the most recent data is that the average age of death, even for really complex stuff, is actually 53. And so you think of single ventricles, Ross's, like transmissions, all that kind of stuff, it's actually now an adult problem more than it's a pediatric problem. And this slide kind of shows the results of that. So in the year 2000, it was the first time ever that there were equal number of children and adults with congenital heart disease. In 2013, it was actually 60% adults, and by 2030, 80% of patients with congenital heart disease are actually be adult patients, and the red is actually patients over the age of 60. And so this really is not just that they're living to adulthood, but they're living into mid-adulthood. And I'm glad that Paul's here, because I wanted him to see this slide in particular. And so when you look at this, this is actually a national inpatient database. It's 195,000 admissions, and this is over an almost 10-year period. And this is the number of patients that are admitted over the age of 60. And so really, the patients that are being admitted are older. There's a 95% increase in valve procedures, and 85% of intervention in congenital heart is actually valve-related. And there was a 57% of increase in pacemakers, so I'm also glad that Chuck is here. And so when you look at admissions, there's a 50% increase in simple admissions, 53% increase in complex admissions, 50% admissions are emergency, and there's a high percentage of sort of the comorbidities that you see in adulthood. And then when you look at the ACHD workforce, and so there's 1.3 million adults with congenital heart disease in the U.S. In 2008, less than 10% of them were actually cared for in a center that had any expertise related to congenital heart disease. And over a 5-year period, 50% were hospitalized, 16% required critical care, and 68% had at least 1 ER visit. And so this is a patient population that is growing, and they have a huge utilization of healthcare. And then this is why we're here and why I'm starting to do this. And so they look at the workforce, they look at the people needed to be taken care of, and they estimate that you should have 450 ACHD providers. In a 10-year period, we trained 50. And so there really is not enough people to do this work with appropriate training. And so we, Minneapolis Heart Institute, Children's Hospital, CHC, we really were recruiting for a director for almost 10 years. And so we brought through, Kirsten Doomer came, and she really didn't want to lead the program. She wanted to sort of be a part of it, and she now has transitioned to a fetal program. But we had all these people come through, and we really were not successful in recruiting any of them. And you're talking about working within 3 institutions, without formalized agreements, and I think that it really has been a hard sell. And so about a year ago, Bill and John and I sat down and we said, let's just stop recruiting and let's just build with what we've got. And so that is what we've done, and that's what I want to show you the examples of some of those cases. And so this is actually a criteria list of what you need to have to be a comprehensive adult congenital center. And so there's a whole list of this, and these all have subsets, but you need a cardiologist, you need a nurse, you need a surgery, you need heart failure, interventional catheterization, and we actually have all these things at both institutions. It's a matter of just bringing them together. It's really not creating anything new. It's just gearing it towards congenital heart disease. And so the evolution of ACHD here has been in 2003 when I first got here. I don't really know what happened before then. It was really kind of case-based collaboration. And so there'd be a case, you'd figure out where the patient should be, and they were cared for in an institution without any sort of programmatic support. In 2005, 2014, we started to have adult congenital clinics, but they were really kind of at Children's, they were at Abbott, the echoes were done at Children's, patients were seen here. There was really no coordination of the care. And so all the echo was done at CHC, all the CT and MRI was done here. And so I think the patients got the care that they needed, but there really wasn't a structural way of sort of coordinating that. So in 2015, I kind of got involved, and we started to say, let's just establish the clinics at MHI. Let's give them a home. And so we'll do all, the echo was still done at Children's. We started to train echo techs, and I think Nicole and Steph, are you both here? So thank you for that. And so in 2016, we said, let's actually, we're still waiting for a director, but let's actually start to build the outpatient inpatient system. So we've expanded the clinics at MHI. So in 2015, there were 6 clinics a month. Now we have 12 half-day clinics a month and a full day on Wednesday starting 2 weeks ago. We began the transition development, but really realized we can't actually have a transition program to a place for them to go. And so now that we have availability here, we're going to build a transition system over there. And then Lou started in March of 2016, and she's been a fantastic addition, has done a lot of this work. And so in 2017, we said we need to start actually building the inpatient system. We need to stop recruiting. We're just going to try to do this ourselves. And so we now have echo coverage 5 days a week as of next month. And so Steph and Nicole actually changed their schedule to allow that. We have monthly working group meetings since March, second Tuesday of the month here at Abbott. We have case reviews since 2016, fourth Tuesday of the month at Tuesdays. We're trying to formalize the surgical collaboration, and we're going to start to establish the transition program. And so that's the kind of stuff we've done within the past year. And so why is this saying cardiopregnancy and adult congenital? And this is the reason why. So I'm a woman, and I'm a cardiologist, and whether I like it or not, I see women. And so this was a list of the people that are coming to see me. And so if you look at this, 23, 31, 24, 25, 29, 26, 24, 22. They all have congenital heart disease. They're all coming to see me, and they're all talking about babies. And so I realized that I did not know anything about this. And so I looked into it, and I sort of got really scared. So this is actually looking at pregnancy in women with adult congenital heart disease. And so 43% of women have never been counseled. The use of contraception, 20% of them are actually on contraception that is contraindicated for their lesion. So you have patients with single ventricles on estrogen, all that kind of stuff. 48% were never told pregnancy is high risk by their physician. They're counseled by pediatricians who don't talk about these sorts of things, particularly when there's a mother in the room and they diagnose the baby as a fetus. So no one's talking about it. 45% of pregnancies are unexpected, and then this is the thing that, that really caught my eye. This is a study in the United Kingdom. 40% of deaths is attributed to substandard care. And that's kind of where I was at. And so I said, if I'm going to do this, we actually need to develop cardiopregnancy in addition to adult congenital heart disease. And so this is actually U.S. data. This is from the CDC. The second most common cause of death in congenital heart disease, or in pregnancy, is actually heart disease. And then when you actually sort of look at the hospitalizations for congenital heart disease, the most common non-cardiac reason for admission is pregnancy and delivery. And so within the last year, I started to realize that if I'm going to be an adult congenital person, I actually need to be also someone that knows something about pregnancy. And so you look down here, this is the criteria, reproductive services. They actually give you all of these things that you need to have. And so we just started to look at these and started to fill in our gaps for what we need to do for cardiopregnancy in addition to congenital heart disease. And so my vision really was, we're going to do this, we're going to do it slow, we're going to do it methodically, we're going to have this stepwise expansion, we'll do sort of moderate and complexity stuff, and as we get comfortable, we're going to actually start to take care of more complex cases. Instead, we are taking care of incredibly highly complex patients. We have had rapid growth of the program, and we've collectively cared for patients at a high level that I have just been astounded by. And I think that we have potential here that really doesn't exist anywhere else. And so I think I've gone from a vision of we're going to try to get as good as the institution down the street to I think we can actually do some things better. And so I think this program highlights the best of Minneapolis Heart Institute, Children's Hospital, Perinatal, Abbott, and Allina. And I think we're pulling the best of all of these people to take care of this really complex group of patients, and includes all of the people in the list here. So now what I want to do is I want to actually go through 3 cases, and I want to show you the examples of the things we're taking care of. And so the first case is going to sort of highlight cardiopregnancy, structural heart intervention, and this is a collaboration with all of these sort of institutions in all of these different specialties. The second case that I'll go through is actually heart failure EP surgery, and the third case is actually almost completely just structural heart intervention. And so I'm going to start with these cases. So when you look at the background, just for adult congenital and pregnancy, I've learned all this in about the last 6 months. There's actually 3 different risk categories that actually show you someone's risk. And this is actually called CARPREG. If you have more than 1 point, you have a 27% risk of an adverse event. If you have 2 points, you have a 75% chance. And so these really are high-risk pregnancies. This one is called Zahara, and this actually looks at congenital heart disease, looks at pulmonary insufficiency, systemic RVs, big RVs, that kind of stuff. But probably the most common one that's being used, and the one that we'll probably use going forward, is actually the World Health Organization classification, what this does is takes all the congenital heart disease and sort of other heart disease and puts you into classifications. If you're class 1, you have the same risk of a pregnancy adverse event as everybody else. If you're class 4, it's actually contraindicated. In this day and age, with Eisenmenger, there's a 50% chance that the mother will die during or after her pregnancy. And so these are really lesions for which pregnancy you should not get pregnant. And please notice down here, mitral aortic stenosis. And so when you look at that, it not only predicts the adverse cardiac events, it actually predicts adverse OB events. And this is actually looking at the mothers and their adverse OB events by their classification. And so it's a really helpful thing. And you can also do it by diagnosis. And so we can say, okay, these are your symptoms, or we can say this is your diagnosis, this is your chance of having a bad cardiac event or a bad OB event during your pregnancy. And so you can now kind of risk stratify people when they come in based on both their symptoms and also based on their underlying cardiac diagnosis. And when you look at these guidelines, the thing that's completely missing is anything about the baby. These guidelines almost treat this like it's a 9-month maternal stress test. And it's not like an Ironman competition where your only goal is to finish. The whole reason you get pregnant is actually to have a baby. And so Jean and Dr. Ketko are here from the NICU, and I thank them for coming. And so I think the whole thing we need to think is, what is the effect on the baby? Because if you're going to counsel a mother, you have a 50% chance of dying or this or that. They think, well, if I get a baby at the end of that, it's actually worth it, right? But what if you tell them that the baby has a huge risk of having something happen? And it does. And this is actually looking at the fetal outcomes from maternal congenital heart disease. And so if you actually look at it, the adverse outcomes in the babies is actually way higher than the adverse outcomes in the moms. And so this is actually looking at simple, moderate, and complex disease. They all have a high incidence of having something happen. This is looking at the class 1, 2, 3. They all have a high incidence of something bad happening with the baby. And these are things like fetal death, neonatal death, premature delivery, small for gestational age, infections. I mean, these are kind of big deals. And so I think we have to talk to the moms not only about what is the risk of the pregnancy, but what is the risk to your baby, which is the goal of being pregnant in the first place. And so what I want to actually do is talk about the case that actually doesn't have congenital heart disease because it was related to pregnancy. I somehow got involved. So this was actually a 23-year-old woman, and she has end-stage renal disease, actually on dialysis 5 days a week, had a transplant previously that was rejected. She had secondary hyperparathyroidism, for which she had very high calcium and had calcified her valves. She had renal vascular hypertension. She had chronic pain, bipolar disorder, suicide attempts, depression, anxiety, opioid dependency. So this woman is very, very complex. She has anemia, and she also has exertional shortness of breath and syncope, and she has severe MS and severe AS, and she shows up and she's 18 weeks pregnant. If you want to talk about doing, the simple stuff, and then we're going to get ready for the complex stuff later, this is what walked in the door. And so her diagnostic evaluation, she had both a transthoracic and a transesophageal echo. She had severe AS. She's almost 5 meters per second, which gives you the super severe. And she also had severe mitral stenosis. And the mean gradient, as we know, fluctuated between being awake and being sedated and casts and those sorts of things. But good function, mild TR, normal PA pressures. And then she had a CT on 2017. And I want to say, is Bill Wagner here? Not yet. He actually came to the scanner to talk her through the scan. And so when you talk about collaboration, that really is what we're talking about. He came down from perinatal to talk to her on a CT scan table because she was worried about the radiation risk. And so you look at all of her other risks, and she's worried that the radiation from the CT is going to hurt the baby. And so I was actually in the reading room, and so I went and talked to her too about radiation risk and cardiac CT and that kind of stuff. And then Bill came down, and he talked to her on the table. And so she did get the CT, and it was recommended that she get a 23-millimeter sapien with 2.3% oversizing, and then she had a right heart cath that showed she did not have secondary pulmonary hypertension. And so let's look at her scores. What are her risks for pregnancy? So she's got 2, and this does not include her renal disease or her mental health issues. She actually has 2 contraindications for pregnancy, so she's not supposed to get pregnant twice. And so when you want to talk about risk, this is as high risk as you can get from both a cardiac and an OB and a baby standpoint. And so when we look at what are her options, she can have a mechanical valve, she can have a bioprosthetic valve, or, and this actually isn't really listed as an option anywhere, she can actually get a TAVR valve. And so the recommendation in all the guidelines is that she should get a mechanical valve. This is what is recommended everywhere. And so when you do that, you're putting someone who's 18 weeks pregnant on bypass. You are committing her to anticoagulation with either high therapeutic heparin or vitamin K agonist, but it is a long-term valve. I think the reason this recommendation is made is because as far as the mom goes, that's the best valve for her. A lot of people in the more congenital world, pediatric world, are saying, why don't we put a bioprosthetic valve in to give a woman a window to have her babies without worrying about all this anticoagulation. And so this actually, I think, is a very reasonable approach. But really no one has talked about doing a TAVR valve. And so let's actually look at the risks of what we consider for a mechanical valve. So if you put someone on bypass when they're pregnant and they are early in gestation, the babies really don't survive. I think that in certain places in the country they probably do, but this is actually looking at cases from 1991 to 2013. The most common indication is for mitral and aortic valve disease, and in developing countries it's a lot of rheumatic heart disease, and so that's what we see a lot of. And the maternal mortality is similar to non-pregnant patients. So you can get the mom through the procedure, but there's almost a 20% fetal mortality, and it's actually highest, if you look right here, the babies who didn't survive were at exactly the gestational age of this mother, 17 to 19 weeks. And so you can get the mom through the procedure, you can give her that valve, there's a pretty good chance the baby would not have survived that. And so let's say that you did get her through that, let's say the baby survived, now you're talking about anticoagulation. And so warfarin crosses the blood-brain barrier and it goes into the baby, and so you get a lot of fetal hemorrhage. And so looking at this, warfarin's the best for the mom, it's the best thing for the mom's valve, but really it's the worst thing for the baby. It causes an embryopathy, and so it's a bad thing. When you look at the heparins, it's worse for the maternal valve, and so the mom is very likely to have a valve complication during the pregnancy if you're using heparin, but it doesn't actually affect the baby. And then as far as delivery goes, you've got to actually stop everything, have the mom uncovered with any anticoagulation for about 48 hours so she doesn't have a postpartum hemorrhage with delivery. And so this is the current option, is that she should be on one of these things. And so instead, Dr. Mooney and the valve team decided to put in a TAVR valve. And so she had a 23 millimeter S3 device deployed. She had a little bit of bundle branch block that resolved, so did not need a pacemaker. Her post-procedure velocity had a mean grading of 13, so it really was a very effective procedure. And now she's only contraindicated for pregnancy once, because now she just has severe mitral stenosis in addition to her bioprosthetic valve instead of both severe AS and MS. And so she was admitted in preterm labor, and the reason it says thank you to Lou is that she was supposed to come and see us, and then somehow it got scheduled with Des J 6 weeks out, and so Lou called her and said, we need to see you, and she said, oh, I'm having contractions. And so Lou told her to go to the emergency room, and she was admitted to mother baby, and you know, it's kind of like one of the things we need to figure out is where do they go. So you have a lady who's got, she's on dialysis with renal failure, she's pregnant, and she's got severe MS. And so where does that patient go? I mean, it really ends up being, she actually went from the dialysis floor to mother baby to the cardiac ICU and then back to mother baby. She got transferred around a lot, but she did have a delivery, 26 weeks, a 1.9 kilogram baby boy, and the 2 neonatologists are actually taking care of that baby right now. And so the other pregnant patients that we have followed is we have 13 patients we followed since January of 2017. 5 have delivered, 6 are currently pregnant. 1 did transfer her care to Mayo, and there's been 1 woman who miscarried. And the diagnosis they've had has been aortic stenosis, TAVR valve, AV canal, ASD, citrology, aortic coarctation. And we actually have a Fontan coming next week, which will be our next adventure. So I think that, you know, when you think about ACHD and cardiopregnancy, I think cardiopregnancy is an essential part of ACHD. But I think that ACHD is only a subset of the cardiopregnancy. And so I think that when you look at it, if you're going to build this program, you need to build it for more than adult congenital. You have to look at arrhythmias, valve disease, aortopathies. There's different recommendations for the replacement of an aorta with you're pregnant versus not pregnant. And also coronary artery disease and dissection. This actually happens in women's health. When you start to look into it, for preeclampsia, it affects 2 to 8% of pregnancies, and it gives you an increased risk of heart disease that's similar to smoking. And so I think this is another thing. So we need to talk about women's health. And so if you build something like cardiopregnancy, it's not just ACHD. It actually has, I think, implications to all these different parts. And this really only works with the collaboration between Minnesota Perinatal, Mother Baby, MHI, and Allina. It really needs all of these pieces to do it well. And Mike, do you have anything to say about that case before we move on to the next one?
No, I think it's, so there's only been a handful of TAVRs in pregnancy done in the country. And I can tell you that without the engagement of the Cardio-Pregnancy Program, we would have been stalled in the care of the patient because there's such apprehension around every decision. Can I take Plavix? Can I not take Plavix? Can we use fentanyl and Versed? Can we use general anesthesia? Can we have a CT scan? There are so many complexities that these highly stressed mothers stall out on. So I just wanted to highlight that it's a very unusual occurrence across the country. There's been less than 10 done in the United States, and I think all of us feel that there's unique resources here that are just wonderful. And a lot of it is due to your efforts to pull us together. So thanks.
Okay. So So our vision really is that we have a transition visit in late adolescence. When you think about it, we're actually talking to people when they're either pregnant or they're there with their partner wanting to get pregnant. When you have someone who's really high risk, they actually should have this information before when they're making decisions about partnerships and whether they want to be parents and that sort of thing. And so what we really need to have is a transition visit in late adolescence that's focused on contraception and pregnancy risk and what's your chance of actually having a healthy baby at the end of the pregnancy. We also, Bill Wagner has agreed that we probably should do the people who are super high risk, they should have their OB and their GYN care actually at the mom's clinic over at Mother Baby. There's no way you're going to educate every OB doc in the cities to use non-estrogen contraception in single ventricle patients. They're going to see 1 in 10 years. And so I really think that taking the highest risk patients and caring for them here is probably the best for them. We also want to have preconception counseling. What is the maternal risk of the pregnancy and for fetal outcomes? And so I think for the women that are Fontans, they actually should meet with the neonatologist at the time that they're doing pre-pregnancy counseling because the chance they're going to have a premature baby is so high, they need to know what that means. And so just kind of review that. And then pregnancy care, I think it has to be appropriate perinatal and cardiology care. And I think we need a fetal echocardiogram and then a delivery plan. And this is one of the things that worked out is where. Because once you actually have a mom with heart disease and a baby, you've got 2 patients. And so you deliver that baby in the Mother Baby with a cardiac nurse that can monitor the mom, or you actually have the mom in the cardiac thing with the fetal nurse that can monitor the baby. And those are the things we really have not figured out yet. We really need to kind of look at that as a program. You know, and also C-section versus vaginal delivery versus assisted second stage versus, routine delivery. And then also, I think we need to have a cardio-pregnancy kind of level 1 equivalent. When you start to look into the literature, the women who arrest are the ones with obstructive lesions. Those are the ones in your TAVR valves. And so when you have a woman arrest and there's a baby there, you have 5 minutes to get the baby out. And so you can't be sitting there trying to figure out how you're going to do it at the time. We need to have some sort of code, whatever color is left, that the code means come do a C-section. I'm serious. You have to, the code means come and do the C-section in the ER because the baby mom is dying. And then you put her in ECMO. And also, let's say you have a mom who has Marfan's and she starts to dissect her aorta. Do you take the baby out first or do you just repair the aorta first? I mean, these are the kind of things you actually have to have thought out ahead of time so that when it happens, you're ready to go. And so I do think we have some work to do on these types of things. And also for a TAVR valve thrombus, what do we use for that? Pregnancy is a hypercoagulable state. Do we use the same anticoagulation or else, or do we actually modify that? I think there's some of these things that if we're going to take care of people at this level, we really have to plan some of these things. So the next patient is actually heart failure, EP, and surgery. And so this is a 33-year-old male, and he's single ventricle. He has been followed by Dr. Singh, then transferred to care of Dr. Carter here, and is now followed in MAC. He has a physiological equivalent of tricuspid atresia, just to make it easier. He had an atrial pulmonary Fontan and revised the lateral tunnel. He's had an aortic valve replacement because of aortic valve insufficiency, sinus node dysfunction, pacer, atrial tachycardia. He's on Coumadin, non-compliant. He is working on his own, has a 4-year-old daughter, and he weighs less than I do. His BMI is 17. And so this is kind of taking his history and dividing into, this is his surgical and kind of medical history, his EP history. So he had BT shunt times 2, had a right atrial pulmonary artery Fontan, had it revised as an aortic valve, and then also had a valve thrombus in 2010 because he wasn't compliant, came in, clotted his valve. You guys took care of him, gave him thrombolytics, and he did fine from that. From an EP standpoint, sinus node dysfunction, has a pacer, has atrial tachycardia, now has an epicardial pacer, and of note, that was actually his 5th sternotomy. And so he has had a lot of surgery, and when you look at the literature, the more sternotomies you've had, the higher risk you are for repeat sternotomy. And so prior to admission, he had a normal albumin, so he does not have protein-losing enteropathy. His AFP was normal, so he probably doesn't have hepatocellular carcinoma, which is now being described in these patients. His BNP is okay. His baseline echo has low normal single ventricle function. He has moderate AV valve insufficiency, and his mechanical valve is functioning well. His pacer check showed that he was mostly sinus, but atrial paced 18% of the time. So there's actually a bunch of things that give you risk factors for bad stuff in Fontans, and he has almost every single one of them. I actually love this graph right over here, because it basically gives you the equivalent age and your chance of mortality by diagnosis. And so I almost love this. You can say, take a Fontan and double their age when you're thinking about them. Don't ever trust them and treat them as they're twice as old as they are. And so he's up here as far as his physiological equivalent of his age and also his mortality. And so he's a 30-year-old Fontan, so very high risk for everything. So if you're over 30, you're higher risk. If you're male, you're higher risk. If you have single ventricle of the heterotaxy variety, you're higher risk. If you have EP issues, you're higher risk. If you have a pacemaker, a prosthetic aortic valve, he's got wasting and frailty. He's got moderately decreased function, and he's got medical noncompliance. And so this guy is really, really high risk. And so he went to Fairview Ridge's ER. He ran out of amiodarone. He said he was taking his Coumadin, but his INR is 1.4. And he shows up, and they did a CT was read as a saddle embolus, which they almost always are. And the reason for that is you're putting the contrast from the superior vena cava into the pulmonary arteries, and the unopathified blood looks like a clot if you don't do it the right way. And so he was actually transferred to Abbott because they thought his Fontan had clotted off. And when he got here, he actually was in flutter. And so this guy was really, really lucky because Dr. Chu was on in the cardiac ICU, who's a part of our program, and Dr. Carter was on call, who was one of our electrophysiologists. And so if this has to happen, he had the right people to take care of him. And so he's given amiodarone prior to cardioversion, and that is completely following. This is sort of the guidelines for congenital heart disease, that if you have complex disease and you have systemic ventricular dysfunction, use amiodarone. And so that's what he got. But he had a PEA he arrested. And so he was put on ECMO urgently in the ICU. His echo showed moderate regurgitation. Ejection fraction was down, but kind of his baseline. And his aortic valve looked like it was functioning normally. Not looked at super well, but the Doppler across it actually looks good in retrospect. 2 days later, he was weaned from ECMO, and he actually had a cardiac arrest when they were pulling the cannulas out. They put him back in, brought him back to the ICU. Now his echo shows moderate regurgitation, probably severely decreased function, and then now there's aliasing across the aortic valve. So it looks like probably what has happened is in the 2 days while he was on ECMO, initially put on with anticoagulation subtherapeutic, he actually clotted off his aortic valve. And so then, like we always do a T, but you think this guy's actually he's got an L malclosed aorta. So his aorta is actually up right underneath his sternum. And so you're doing a T to look at a valve that's in the wrong spot. And so weren't able to see the aorta. And so what we did is a cardiac CT. And I want to say this is probably the only place in the country where you can call somebody and say, Dave, I want to do a CT on a Fontan and ECMO, and he says, what time? I mean, that's pretty impressive. And so as you can see here, this one won't play. As you can see, the aortic valve actually is clotted. And so you can see this valve is actually functioning well. You can see that this, this one's functioning sort of okay, low cardiac output, bad function. This one is stuck, and you can kind of see that here as well. And so trying to figure out the timing of this was tricky. You know, you're putting the contrast in, it's being sucked out by the ECMO cannula, all those sorts of things. And this is kind of a higher look at that. So here's your ECMO cannula in the Fontan circuit. And what you see here is this is his prosthetic valve. And so he's got his clot on the top of the valve. And so these two little things are probably clot. And then under here is what we see a lot. We often see pannus, which is on the undersurface of the valve. And it's kind of like the scar tissue that kind of comes in on the undersurface. And so based on this, he said, okay, you know, he's got clot here, he's got pannus here. The valve was working well probably about a week ago, and it's not now. And so what are our options? And so we started to think outside the box because his surgical mortality is so high. And so when you look at it, you can do surgery or fibrinolytic therapy. And so we really started thinking, can we do fibrinolytic therapy? Because this is recent onset, it's small, and when you look at the risks of surgery for this guy, they're really, really high. And so we did talk about this for 2 days, and we started talking about, if you're going to do it, how are you going to do it? And there's actually a couple of articles now. Paul actually got me this one. And this is another one that came out for pregnancy. You know, there's an option of doing your regular stuff, but you can't do a bolus. And of course, none of these studies include a single ventricle Fontan on ECMO. And so what we ended up doing is doing thrombolytics times 2 doses. We used the 25 milligrams for 6 hours. And he actually did okay. There was no change in the valve gradient, but there was an improvement in the function. And so I have to think that that probably did get rid of a little clot on the top of the valve. He had some bleeding at the groin site, and then he dropped his hemoglobin. And so at this point, we actually got him palliative care. Like, there's no way this guy's going to survive an operation. And Dr. Ben's son is here, and I want to thank him because he actually wasn't even involved in this case. He looked at the CT and got interested and said, well, why would you do a sternotomy? Why don't you do a minimally invasive surgery from the thorax? And I'm like, well, I've never heard of that. And so he actually went in right here. We could show him on the CT exactly where to go. And he put in a bioprosthetic valve in that position. So, right, and you think about it, you're doing a sternotomy, and you're actually trying to look up under the rib, you're looking way up under there trying to replace a valve, and you got the coronary here. And so 5 sternotomies, tons of scar tissue. This is a really complex operation. We didn't think he would survive. And Dr. Sun did this through an incision that I went to the OR, I think it was about this long. In perfect visualization of that valve. It was technically spectacular. And 2 days later, he's off ECMO. He is home. And he was seen, I think, 2 weeks ago, and he said he's about 80% of normal. And so I just think this is a remarkable case that shows the collaboration and the potential here that we really don't have other places. And the bigger questions for him really are his long-term options. That list of risk factors he has, he still has all those. And none of those have gone away. And, you know, does he get a transplant? Does he, at the time, he was not a transplant candidate because he's not compliant. He comes in, it's the second time he's clotted off his valve, he's not on his amiodarone. But, you know, is he still a transplant candidate? I don't know. His risk of not doing well is very, very high. And so I think, you know, these are the kind of things we have to think about as well. So Dr. Stone, do you have any comments on that case?
Sometimes ignorance is bliss, right?
Yeah.
You know, we look at things with different perspectives, and that's what makes, you know, us better with the sum of our parts, that kind of concept, because doing non-sternotomy approaches is something that, you know, we should be thinking about more and more for anything. And that's what makes us strong, right? Because we have so many different perspectives trying to come in on these complex cases. Somebody's going to come up with a good idea at some point.
And it was you, so thank you. And so this case actually, my only, this is Paul's structural and every person's heart team. So the 44-year-old guy, he has tetralogy, flow, and Noonan syndrome. He's actually been followed not by the adult congenital team or by congenital cardiology. He's actually followed by the heart failure team. And so he had complete set repair of the transducral patch. He then had an aneurysm resection. He's had 2 pulmonary homografts. He's had 3 tricuspid valves. And he also, by the way, is transfusion-dependent diamond-black-tan anemia and has chronic atrial fibrillation, and he's class 4 heart failure. He's in the hospital all the time. And so my contribution to this was actually doing his imaging, and actually Jana is here as well. And so here is his cardiac MRI. You can see here's his second pulmonary valve. It has severe insufficiency, 43%. You can see here is his tricuspid valve, his prosthetic tricuspid valve. EF is down. And so here's a guy who is class 4 symptoms. He's had 5 sternotomies. He's got a really big right ventricle, and he's got 45% PI. And the question is, can we actually make him better by giving him a new pulmonary valve? And everyone says yes. And the question is, how do you get there? So normally, he's considered very high risk for surgery because he's got anemia, he's transfusion dependent, he's on chronic steroids, and all those other kinds. So the surgical risk is very, very high. Usually we'd put in a melody valve and call it good, but you can't get to the heart with a normal thing because you got a prosthetic tricuspid valve there. And this is where the valve team really thought outside the box. And they said, why don't we just do it through the chest wall and put it straight in the ventricle into the heart? And so that's kind of what they did. So here is the CT we did. You can see he does have a circumferential landing zone that is nice and solid, calcified. You can see here is the mechanical valve, and here's this. And then what Dr. Lesser is teaching me to do is to actually plan how you're going to get there by using your CT data set. And so this was the CT image, and they actually put a little marker, I think, on the patient right here, saying we're going to go in here because that's your straightest shot at getting at your valve. And then we're going to, this is your cannula actually in the procedure, and then this is the valve after it's been deployed. And I just looked at his chart last night, and so he was seen in early October, I think October 3rd by Dr. Cabaway. And he said lost to follow-up since the procedure. He has not been in the hospital since he got that valve put in. And I think that before that, he was basically in the hospital all the time. And so he's still not a transplant candidate, but you've given him a quality of life. He was discharged to the care of his sister with the expectation and he's actually moving out of the house, he's moving in on his own. And so this is another example, I think, where what you've invested in the valve program has direct implications to congenital heart disease. And Paul, do you have anything to say about that one?
Great team effort, and you know, every time Dr. Hahn calls me, I'm always thinking, what am I going to get to see next? It's always incredible what you show us, and just thank you for your efforts. It's a lot of fun to do these, and always happy to be a part.
So now what I want to do is actually talk about the times when we have nothing to offer but kindness and compassion at the end of a life. And it's more often than we would like in these cases. And this is a 45-year-old male with tricuspid atresia fontan, chronic PLE for 15 years. He happens to weigh 375 pounds, which is down from 450. He was made of cellulitis, diastolic dysfunction, ascites, renal insufficiency. He's on a latest infusion. And if you dried him out, his kidneys failed. And if you let him have water, he was in complete pulmonary edema. And so we really have nothing to offer this man. And so Leslie Macho and the palliative care team, Erin Novak from MedPeds was involved. I rounded on him every day for 2 weeks because he told Lou that when he died, no one was going to miss him. And he wanted to go to hospice with his cat. And Leslie actually arranged that, and he did go to hospice, and he died about 10 days later. This is a 29-year-old woman with Down syndrome, Eisenmenger's, baseline saturations in the 80s. She's on 2 pulmonary vasodilators. She presents with pseudomonas sepsis. She's on epivasopressin with intubation stats with 50. And Dr. Lesser, I think, ran to the ICU and said, please don't put her on ECMO. And I talked with the family several times, and she was made DNR. And despite maximal medical therapy, she died. This is a 45-year-old man, transmission followed by Dr. Carter, severe RV dysfunction and atrial arrhythmias, non-compliant. He has multi-substance abuse in addition to alcoholism. And check out this right ventricular end diastolic volume, 681. It's the second biggest I've ever seen. The index line was 336. And so he is failing. His ejection fraction is 15%. And he died in his sleep a couple of weeks ago. And so I just want to say thank you to the palliative care team and also the MedPeds team, who I think has been absolutely critical in taking care of these patients. And so I kind of want to go through the current state of where we're at. And so when you look at the outpatients, what we've done is since July, we've had our own scheduler, who is Laura Wentz, who's really done a fantastic job. And before that, it was really kind of hard to get. We have an outpatient clinic at MHI since January 2016, and we've actually doubled the patient visits in the past 2 years. And as of October 2nd, I think we have full day on Wednesday, and we have other 12 half-day clinics. And then the EP nurses have been spectacular, and they really have stepped up, and they're going to start to cover some of these patients. And I think they signed up for EP and ACHD, but I don't know if they know that they signed up for EP and ACHD and Cardio-Pregnancy. We'll have to figure that out. We have 2 echo techs that have trained since 2016, and that's Nicole and Steph. And so starting in November, we're going to have 5 days a week echo coverage for adult congenital. We're going to have a 3rd echo tech start in December, and that's going to be Molly. And so from what I can tell, I'm getting some of your best people. And we need to get an echo template. I tried the report generator, but you have to have 2 ventricles and 4 valves for that thing to work. And if you don't, I tried, but it just doesn't work. And so we need to work on that. And Lou has been here since 2016, and again, anyone that's worked with her knows that she's spectacular, and she's been integral to the success. We also, so the patients, whether they're seen at surgery at Children's or surgery here, they're all going to the Abbott pre-op clinic to look at all the adult comorbidities, and that has happened since July. Since September, we've had the Coumadin clinic here take on the patients. So what's happening for a while was that the patients would still be followed at Children's for Coumadin, but they were followed over here clinically, and so we now have that in the same place. We do have, since January 2015, we have a clinical case conference once a month. And tomorrow, we're presenting 10 cases. If anyone wants to come, it's over at Children's. We're presenting a 29-year-old with a Glenn who never showed up for his Spontan, who is symptomatic with polycythemia. And the reason he didn't show up is he got his Glenn. He said he felt so good. He's like, this is the best 5 years I've had in my life. And so I'm just saying, this guy's crazy. He's like, I actually had a really good 5 years. But the question is, now he's polycythemic and asymptomatic. To get a Fontan, we have a 33-year-old with a Ross procedure who has an obstructed RV to PA conduit, and his knee aorta is 5.5 centimeters. And what do you use for the criteria to replace it when it's, a Ross? No one really knows. And we have another case that actually came from Mayo, and he's a 29-year-old, and his wife's dragged him in because they're pregnant with their first baby. And he has an atrial pulmonary Fontan, side node dysfunction, and arrhythmias. And so the 2 options are going to be either an EP study with an epicardial pacemaker or a Fontan revision. And then that's just 3 of the cases that I can think of off the top of my head. So 10 cases tomorrow. We actually, starting in March of this year, we've had a monthly working group. And what we're doing basically is I've used this as an educational process for myself. And so what I do is I show up half the time, say do something every day that scares you. I mean, for me, it's been coming to work. And so what I do is I take the case and say, what don't I know? And then I try to build the educational conferences on that to teach myself and other people the things that we need to know to take care of these patients. And we also have a consult service as of March 2017. And so now, if you have a patient with congenital heart disease, you can actually call and hopefully we'll answer the phone and show up. And then we also, now that we have the clinic availability at MHI, we can actually start the transition process over at Children's. We really couldn't do the transition process until we had availability here. Looking at surgery, we have 35 cases in the past 12 months. And if you look at, we have 10 cases tomorrow. It's going to be, I think the surgical volume is increasing very quickly. The mean age is 30, the range is 20 to 62 years of age. And just randomly, the cases have kind of fallen half and half between Children's and Allina. And Dr. Moga has been operating with a lot of the surgeons here. And I should have been son on there because he did that other case. And Dr. Moga agreed in September that he's been scrubbing all cases. And he said that he's going to be a primary surgeon here within a year. And I actually looked back, and that meeting was on August 9th. And so I'm going to hold him to that date. Imaging, I think I work with the best team I've ever seen. And half of the MRIs and about 30% of the CT is actually patients over the age of 18. And I just had to show some pictures because this is what we do. 25-year-old aortic coarctation, so don't always assume hypertension is because of hypertension. This was actually a 53-year-old who had the same thing, and she had hypertension during her pregnancy, and it was called pregnancy-induced hypertension until she was 53. This is a systemic right ventricle. It's a prosthetic tricuspid systemic AV valve. This is an atrial pulmonary Fontan, stuff like that. And so, I think that when I think of how are we going to do this, I think, how do we approach CT? I'm not trained in CT. And I said, I'm going to show up every time. I'm going to do the best I can. I'm going to fill in my knowledge gaps of things I don't know. I actually went to a radiology board review course to sit there and learn how a CT scanner works. And then I'm going to be better next time. And I think that if we take that same approach to congenital heart disease, I think that we can have success. And so with that, John and I helped write the 2015 guidelines for CT, the first ones that ever exist, and on the appropriate use criteria for the ACC for multimodality imaging. And for most of the things that they send out, CT is completely blocked out as you should even consider as an option. And that would include prosthetic valve. So what do you mean you can use CT to look at a prosthetic valve? I'm like, you can. So in Washington, D.C., in just a couple months ago, John and I put on the first ever CT course for congenital heart disease. And so we want to have an educational platform where you can actually come to learn how to do this stuff. I'm the core lab for a catheter valve for native RV output tract. They approached us to do it, but MHI wasn't equipped yet to be a core lab, and so I actually approached Jonathan Leipzig and Philip Blanke, and so they're the core lab. They're doing all of the work, and I just get to be the expert reader, and so it actually worked out really well. And then we also are starting a registry for congenital heart disease in dose. And so I think that if we take the same approach that we took for imaging and we use combined, and John and I think have learned so much from each other. And so I'll say, hey, look at this. And he knows now what a unifocalization is. I know about the pleomorphic effects of statins. I mean, I think there's all this crosstalk. Actually, I don't really know anything about that, but there's all this crosstalk that happens. And I think that if we do that for every specialty, that we really can be successful. And so I want to show you the current state of cardiopregnancy is this. And so Mike, when you said we're going to market it, I had a panic attack. We really are just kind of taking this case by case for now. I do think we need to approach it in a more systematic way. And Bill Wagner's great. And Joellen said she wanted to be involved. So she got on here. And Chuck Gornick actually has followed, I think, the most patients in the practice. And so he really is a part of that. And I've come to appreciate Chuck the way the rest of you do, because every time you call, both he and John come, and they always answer their phones. And so transition, the reason that transition is so important is if you actually look at this, this is the number of patients that actually see a cardiologist by the age of 18 versus the number that are in their care. And so you think about it, 50% of kids are born to single parent families, and 50% of the kids are in families that get divorced. And so who you talk to at birth is not who you're talking to when the child is 18. And so a lot of people don't even know they're high risk. And they're told, I mean, when you think about it, like the single ventricle patients that were followed by the older cardiologists, they started practice when every hypoplast died. And so what you did when you saw hypoplast is you wrapped the baby in a blanket and you handed it to the parents and you sat there with them while the baby died. And now they're seeing hypoplast for 18. They're like, oh my God, you are doing great. And so what they mean is that you're doing great because everyone used to die. And what the patient thinks is I'm great and I'm normal. And so I think that, the message that is heard, you don't want to say bad stuff. And so we need to be better about educating people, and we need to be better about keeping these patients in the medical system to actually know if they need care. And this is actually also looking at, by severity of heart disease, neurodevelopmental difficulties. And so with scheduling, say, well, the parents shouldn't call for an adult, they should call themselves. And kind of like, well, I don't know that some of them can. They haven't been taught to, they can be delayed. And so we really want to have this be a whole program. We can start it now. We have clinic availability. And I think what we're going to do now is just establish a transfer visit saying, okay, this is your heart disease. This is your risk of all this stuff. Because what's happening is they're told you're great. And they come and see us and like, okay, you know what, you actually have increased mortality. And we tell them all these things and they say, we don't like MHI. And it's not that they don't like MHI. It's that they don't like the message that we're giving. So we want to actually have them hear the message on their side of the street before they come over. And then over the next couple of years, we'd actually like to implement a full transition program. And if you look at it, that's, it's a lot of patients, and it'll be a lot of work to do that. But I think it's really, really important. The parent doesn't have to come to every visit. The patient can. Separating all that out and teaching. So this is one of our next things. And so I think that, what are our next steps as an institution? I think we need to go from individual commitments to sort of formalized institutional commitments. And so I think that, right now we have very people that are all in this room that are committed to doing this. So we need to have the institutions committed as well. And so we are going to update the letter of intent. And there's also ongoing discussions. Because I think that, when you start thinking about the logistics, it's as complex as the patient. Who bills, who sees them, where do they go, how does that all work is complex. And then I think that for intervention and surgery, I'm hoping that our next step is going from supporting the procedures to actually being involved in the program development. And so rather than just doing the cases when they come, let's think about it from a systematic standpoint. Where do they come, where do they go, who follows them, where they get admitted, the cardio-pregnancy kind of arrest plan. And I also think we need to, at this point, develop non-cardiac specialist support. And this is hematology, it's respiratory, it's infectious disease, nephrology, GI, and this is where I think the EP or the med-ped people are critical. And also nursing, respiratory support, everyone else in the hospital. And so we need to move from sort of like the baseline cardiac specialties to all the other cardiac specialties and all the support staff that we need. And I also think that it's critically important that we develop data and quality improvement mechanisms. We need to know that we're doing this and we're doing it well. We need to be honest about our mistakes. We need to learn from them and be better next time. And so that's, I think, one of the other things we really need. And so I want to say thank you to all the people. I know I missed people. And so I want to say, so Pam Glick, for a while, if you called here and you asked for me, they would send you to Children's Heart Clinic. Say, well, she doesn't see patients here. And so I think Pam actually went to every scheduler, and she made sure that every one of them knew that if Dave Burton or Chris Carter or I saw a patient here, that was our patient. And so I thank her for that. Nancy Newell also is the one who helped us get a scheduler. Jana and Dave are fantastic. Jill has helped with this Tamara, everyone knows Tamara. And that's actually all the EP nurses. So taking on these things that are scary and different, and I know they're going to do great. And then
So I'm Dave Burton. I'm one of the cardiologists over at Children's. And as you can see, I mean, what Kelly did is really fantastic. We really haven't had, up until now, really any opportunity for cooperation. We have had. I mean, I've had cooperation with Chuck and the EP team, but it's been kind of difficult, and we really haven't had success in building a program. Part of that is because the number of patients has been somewhat small, but as we go forward, I mean, it's like Kelly said, we kind of feel as pediatric cardiologists that we owe this to our patients to be able to take care of them when they get to be adults. And you can see how freaking complex it is. I mean, it requires a tremendous amount of effort, coordination, time, skill. I mean, all things that, you know, we have, but it just has to get together. Because I would say, you know, before this time, I mean, the only really program that has it together is Mayo. And we have had to send patients down to Mayo because we just didn't have the ability. You know, we see a patient who's really complicated, and where do we send them? And I think a lot of the patients in the past from our group of cardiologists that have retired, I think a lot of those have gone to Mayo because they just didn't know where to go because we didn't really have a quote-unquote program. But as you can see, I mean, we really need it. We really owe it to us, our patients, and just like Kelly says, I see a patient, I mean, when I'm not here anymore, I want to make sure that my patients are getting what they need. And I think they get what they need here. It just takes a lot of coordination effort on everybody's part. And the skill level here is tremendously high, tremendously high. So it's the collaboration between Children's and Abbott and all the other departments that's going to make this happen. And it's really very encouraging and nice to see that, you know, Kelly's taken the time and effort to try to put something together that I haven't really seen before. And I, you know, commend you for doing that.
Yeah, awesome.
Thank you for the great presentation. I have a question regarding the cardio-pregnancy, and you mentioned the high mortality of the fetus during the cardiopulmonary bypass run. I have a question, maybe there's no answer to it, but is there a theory that this is because of the variation in the hemodynamics and the placental blood flow, or do we think that this is because of how the bypass usually precipitates the inflammatory response in the body? And is there any data on mechanical circulatory support on the pregnant?
So I think it's both. And when you look at it, they talk about doing normal thermic and a higher mean arterial pressure for the bypass. And so they actually, like, when you look at, and Mayo's done a lot of it, which is why I think they recommend doing mechanical valves, is they'll actually they change the bypass, and they actually have OB in the thing monitoring the baby, and they actually adjust the bypass for the placental circulation. And so I think that with that approach, I think that it's better, but I still think that when it's done in the really early gestation, that there still is a high, probably because of all the other things you mentioned. But they do adjust the bypass based on that, and they do it at a higher pressure, and they do it normal thermic, and they monitor the baby, and they monitor placental perfusion. At least that's what I read. I don't really know.
Any other questions?
I'd like to just comment on something I think all of us are thinking, and that is that this institution and our joint institutions share a reputation for taking on difficult work. And this it may not be a huge number of patients, but the patients that we help are very visible in the community, and they greatly add to our perception as a destination for excellent care. So the halo effect from all the extraordinary efforts of the teams taking care of these patients is broad, and it includes all of us. So when we see these patients in the hospital, they push us out of our comfort zone, but mind you, they're supposed to. These are very difficult patients, and as leaders within our various programs, our job is to provide calm and say, it's supposed to be difficult, it's supposed to be hard. And with Kelly's help, we'll have communication. There's extraordinary talent. When you call for help, you really get good help. So you are not alone in taking care of these patients. And jointly with good communication, we, I think, can be among the very, very best. So thank you, Kelly.
Thank you all very much. Next week, we have Dr. John McCabe speaking, so we'll look forward to him. Thank you very much. Have a great week.